Hello, everyone. Today, I want to share with you my vision for my future practice, not as an abstract career plan, but as a response to a very real and urgent crisis in American healthcare. This presentation is titled Healing the Forgotten because that is exactly who I intend to serve: the communities, the patients, and the families that our healthcare system has consistently overlooked. As a family nurse practitioner, my goal is to serve those who have been left behind by the traditional healthcare system. Rural and underserved communities face a compounding crisis: provider shortages, poverty, geographic isolation, and systemic neglect. According to the Commonwealth Fund, more than 60 million Americans, that is 1 in 5, live in areas with too few primary care providers. My vision has three pillars. First, establishing a presence as a primary care provider in these communities. Second, partnering with churches and community organizations to bring mobile clinics directly to people where they live and worship, removing the transportation and cost barriers that keep patients away. And third, becoming an advocate who bridges the gap between patients and the systems that should serve them. This role is not just a career, it is a calling. While the FNP credential might be the foundation of my practice, serving underserved and rural communities will require us going further. Rural health practice is distinct. You are often the only provider for miles, making clinical decisions without easy specialist backup. Programs like those offered through the National Rural Health Association provide targeted preparation that general NP programs do not. Cultural humility training is not optional in communities shaped by historical mistrust of healthcare institutions. Research by Borhaus and colleagues confirms that NPs who are prepared for diverse patient populations achieve significantly better outcomes and patient retention. Telehealth proficiency is increasingly essential as a bridge across geography, and the National Academies of Sciences identify it as a key strategy for extending primary care access in shortage areas. Additionally, multi-language fluency, grant writing skills, and faith community nursing knowledge will multiply my effectiveness as a clinician and advocate for my patients. My plan does not exist in a vacuum. It is shaped by powerful external forces, and I need to name them. Socially, the communities I want to serve face layered disadvantages: poverty, food deserts, limited education, and historical trauma with healthcare institutions. Artiga and Hinton at the Kaiser Family Foundation note that social determinants of health account for up to 50% of health outcomes, meaning that clinical care alone is not enough. Legally, the state I practice in will determine my independence. Full practice authority states allow FNPs to establish independent practices without physician collaboration agreements. This is crucial for rural sustainability, as the priests and colleagues demonstrated in their landmark Nursing Outlook study. Economically, understanding FQHC designation, rural health clinic funding, and Medicaid reimbursement structures will determine whether my practice is financially viable long term. Globally, the COVID-19 pandemic revealed how quickly infectious diseases devastate under-resourced communities. A global health perspective helps me stay ahead of emerging threats and advocate for equitable public health preparedness. Every practitioner should know who paved the road they are walking on. My APRN pioneer is Dr. Loretta Ford, who in 1965 co-founded the first nurse practitioner program at the University of Colorado alongside physician Dr. Henry Silver. Her motivation was identical to mine. As Aruda and colleagues note in the Journal of the American Association of Nurse Practitioners, Dr. Ford saw firsthand the acute shortage of primary care in rural Colorado and believed that nurses, properly trained, had the knowledge, skill, and judgment to fill that gap. She was right, and she proved it against significant opposition. Physicians questioned the model, and even some nursing faculty were skeptical. But Dr. Ford persisted, and by 1973, there were 65 NP programs across the country. Today, there are over 350,000 nurse practitioners in the United States. Her persistence is a direct model for me. Every time I encounter resistance to full practice authority legislation or skepticism about the NP role, I will think of Dr. Ford and recommit to the work. As Porter O'Grady wrote in 2025, Dr. Ford's legacy calls every NP to lead through influence, vision, and action, not just through title. My Christian worldview is not separate from my nursing practice. It is the very foundation of it. The beatitude on this slide, "Blessed are the peacemakers, for they shall be called children of God," speaks directly to why I am drawn to underserved communities. Peacemaking is not passive. It is the active pursuit of justice, equity, and wholeness. In healthcare, that means showing up where others have not. When I provide care to a patient who has never had a consistent provider, I am making peace. When I advocate for a community that has been politically invisible, I am making peace. The Hebrew concept of shalom, complete well-being encompassing body, mind, spirit, and community, beautifully frames holistic nursing care. As the national academies remind us, nurses are uniquely positioned to address social determinants of health precisely because we see the whole person. A Christian worldview calls me to see every patient as made in the image of God, deserving of the best I can offer regardless of their zip code, income, or immigration status. Serving underserved communities is not charity, it is obedience to a clear call. This beatitude is my vocal compass. The communities I am called to serve are not a burden. They are a privilege. They will make me a better clinician, a more creative problem solver, and a more faithful follower of Christ. My plan as an FNP is anchored in three commitments. Faith, because the Beatitudes call me to be a peacemaker in a fractured healthcare landscape. Excellence, because the people I serve deserve nothing less than my best preparation and continuous growth. And advocacy, because good clinical care alone cannot fix systems that were designed to exclude. Jesus said in Matthew 25, verse 40, "Whatever you did for one of the least of these, you did for me." For me, that is not a metaphor. It is a job description. Before I can make the case for my role, I need to paint the picture of why it is so urgently needed. The American College of Physicians report that over 60 million Americans, that is 1 in 5, live in rural areas. Of these, more than 7,600 geographic regions are federally designated as health professional shortage areas by HRSA. People in rural communities live, on average, 5 years less than their urban counterparts. The uninsured rate is 3 times higher. These are not statistics in the abstract. These are real families without a doctor, real patients whose diabetes goes unmanaged, and real mothers who cannot access prenatal care. The physician pipeline has not solved this, and the Commonwealth Fund confirms it will not in the foreseeable future. But the nurse practitioner pipeline can. McMenamin and colleagues conducted a systematic review showing that NP-delivered primary care is associated with reduced hospitalizations, equivalent quality outcomes, and lower costs compared to physician-only models. My entering this field is a direct and evidence-based response to these numbers. One of the most important legal factors shaping my plan is full practice authority, and I want to take a moment to explain what it means and why it matters so much for rural care. The United States does not have a single national standard for nurse practitioner scope of practice. Each state sets its own rules, and they fall into 3 tiers. Full practice authority states, now more than 27, as documented by the priests and colleagues, allow FNPs to evaluate, diagnose, prescribe, and practice independently without a physician collaboration agreement. This is the environment where sustainable rural solo practice is actually possible. Reduced practice states require some form of physician collaboration, adding cost and logistical complexity. Restricted practice states require direct physician supervision, which effectively makes independent rural clinics impossible. Bay and colleagues found in a border analysis study that full practice authority reduces the likelihood that a county is designated a health professional shortage area and improves patient access to primary care. The evidence strongly supports FPA expansion. My commitment is clear. I will advocate for full practice authority in my state and be strategic about where I began my practice. Understanding who I will serve helps clarify what skills and training I need to prioritize. My primary population will include agricultural workers and migrant families, a group that faces extraordinary occupational hazards, language barriers, and near total lack of consistent primary care. Juan and colleagues at UCSF found that NPs who serve in underserved settings are substantially more likely to care for the uninsured and Medicaid-enrolled patients than other providers. Elderly rural residents managing multiple chronic conditions will be another major group. Transportation barriers and poverty mean they often defer care until they are in crisis. Uninsured and Medicaid-enrolled adults need preventative care they have gone without for years. And children in rural settings often miss developmental screenings, vaccinations, and mental health support simply because there is no available provider. My integrated care model operates across 5 functions: prevent, manage, educate, refer, and advocate. Pogsyan and Carthon describe this kind of holistic, socially aware NP practice as a key untapped lever for reducing health disparities in the United States. None of these 5 functions can stand alone. Together, they form a complete approach to faith-informed, person-centered care. No vision is honest without naming the obstacles. Serving underserved communities comes with real and serious challenges, and I want to address 3 of them directly. First, clinician isolation and burnout. Working alone in a rural setting with high patient acuity, limited specialist support, and little peer interaction is emotionally exhausting. The Commonwealth Fund identifies burnout as the leading threat to the rural primary care workforce. My response: I will proactively invest in peer consultation networks, clinical supervision, and my faith community as a source of spiritual renewal and accountability. Second, financial sustainability. Medicaid reimbursement rates are often below the cost of care, and rural patients may have limited ability to pay. My plan is to affiliate with a federally qualified health center early in my career, leveraging their sliding scale infrastructure, federal funding, and billing systems. Third, patient mistrust of healthcare, especially in communities of color and communities with histories of medical exploitation. No clinic can overcome decades of institutional harm by simply opening its doors. Presence before need is the answer. I intend to be known in the community long before anyone needs to see me clinically. Every challenge has a response. That is what planning with faith looks like. Every calling needs a plan, and every plan needs a timeline. Here's how I see my first 5 years unfolding. In year 1, the priority is credentialing and foundation. I will pass my ANCC FNP board examination, obtain my DEA license, and establish myself within an FQHC or rural health clinic. I will also begin Spanish language training immediately because language access is healthcare access. In year 2, I'll focus on clinical excellence and community trust. This means earning rural health certifications, becoming proficient in telehealth platforms, and beginning to show up at community health fairs and local churches, not as a provider, but as a neighbor. Year 3 is about program development, helping launch or expand a mobile clinic, writing my first grants, completing cultural humility certification, and beginning to mentor nursing students who share this calling. By years 4 and 5, I see myself moving into a leadership and advocacy role, contributing to full practice authority legislative efforts, potentially pursuing an MPH, and exploring whether independent clinical ownership is the right path for sustainable community-rooted impact. The National Academies and the AANP both call for NPs to take on leadership beyond the bedside. This timeline is my commitment to doing exactly that. A full list of the scholarly sources cited throughout this presentation is available on the final 2 reference slides. Thank you so much for watching my presentation, and have a wonderful day.